we were pretty much just looking at an overview of the structures that are involved in the kidneys, specifically the nephron, and a little bit in the collecting system. So this was sort of introducing some of those structures. And again, we'll continue to repeat this exposure to each segment of the nephron and then talking about how it differs in structure and therefore how it differs in function. So although we sort of just introduced this very loosely here, this is a really good study tool to then add some more details as we go along, as we add aspects of renal balance and function in some of the future packets. And then one of the last set of structures, more microscopic structures here that we did not introduce, was the juxtaglomerular complex, sometimes called the juxtaglomerular apparatus. And it's a cluster of 3 different cell groups, 3 different cell types that are located at this region, which is called the vascular pole. And just to backtrack here a little bit, really highlighting the anatomy here. So where the distal convoluted tubule comes into close contact with the afferent and efferent arteriole, this is known as the vascular pole. And so I really want to repeat this while I keep drawing the nephron in this sort of simplistic and schematic way. We want to understand how this is really all convoluted together and how the distal convoluted tubule actually wraps around and comes in contact with these proximal parts of the nephron, with the afferent and efferent arteriole. And so the cluster of cells that are located in this region are going to be really important in terms of balance. And we'll talk about the function later on, but just to introduce where these cells are located and how they differ, the macula densa cells are located along the distal convoluted tubule. So again, that distal part of the tubular structures is where we find the macula densa cells. And you may see some controversy if you read up in other literature that say that there are macula densa cells found in other parts of the tubule, but for the purpose of this course, we're going to stick with the DCT. Okay. The second group of cells that are part of this complex are the juxtaglomerular cells, and these are lining the afferent arteriole, right? So this is the afferent arteriole sending or bringing blood toward the glomerulus. And then lining that afferent arteriole is where we have the juxtaglomerular cells. These are the cells that specifically secrete renin. Okay, and we'll talk a little bit about the function of renin coming up. Then there is the extraglomerular mesangial cells. Now, these are not a part of the glomerulus itself, hence the term extraglomerular, but they're actually in between. Okay, and the arrows here may be a little bit difficult to appreciate that, but they're in between the afferent and efferent arteriole, sort of nested in the center of these 3 structures here. Okay, so that's the macula densa, which is a part of the distal tubule, distal convoluted tubule, the juxtaglomerular cells, which are lining the afferent arteriole only, the mesangial cells or extraglomerular mesangial cells, which are nestled in between the afferent, efferent arteriole, and then the DCT peripherally here. Okay, these structures help with erythropoietin secretion as well as renin, specifically the JG cells secrete renin. And so these are going to help in the endocrine function that's associated with the kidneys. And then renin we'll talk a lot more about later on, but renin is really involved in regulating blood pressure as it does so through regulating blood volume. So it's going to help the kidneys adjust how much sodium and fluid are reabsorbed or secreted, and therefore influence blood pressure. And then erythropoietin we spoke a lot about before. It's going to be involved in the stimulation of erythrocyte production. So it's made here by the complex cells. And again, it's not entirely sure which of these cells, the way that we can pinpoint renin coming from JG cells, it's not entirely sure which of these 3 cells in the complex secrete erythropoietin specifically. But then we know that erythropoietin is going to then have an influence on the bone marrow and result in that erythrocyte maturation and production. Okay. All right. So let's get into objective 3 here. So that was kind of the last structure to introduce, really some of the cluster of cells that help in kidney function as well. And so in the last objective here in this packet, we're going to talk about some of the other associated structures in the renal system. So the renal system is not just kidney, excuse me. We also have some associated structures that help with the voiding of that urine as it's being produced in the kidneys. So we've got the ureters, which are going from kidney to bladder. We've got the urinary bladder, which is a singular structure way down in the pelvic cavity. We've got the urethra, which is the tube that exits the body. So it's going to lead to the orifice where we can void that urine. And those, again, are also associated in the overall renal function. So the ureters are the tube-like structures, so you can see them here on the right and left, here they go, that basically exit the kidney at the hilum, so the minor and major calyx, and eventually the urinary pelvis becomes the ureter on either side, and that travels all the way down to the bladder via this, this ureter. So we've got two of them coming from each kidney. They're basically going to enter the bladder at the posterior inferior aspect. So although it's not shown here, it's kind of hidden behind this view. They're going to go all the way down here and then pierce the bladder at this opening. So these are called the ureteral openings, right, on either side here. And then this is leading up to a region of the bladder, again, at the posterior inferior base, that's called a trigone. And the trigone is a really sensitive area of the bladder. This is what's responsible for detecting when it's time to void the bladder, whenever there's that stretch happening in the trigone. And so it's an area of smooth muscle that's very sensitive to the volume of urine that has been filled into the bladder. Okay, so this is what the bladder looks like. It's pretty much a muscular ball. Its main function is to store urine, so it doesn't fine-tune the urine in any way, it doesn't add or take away any substance from the urine. All it does is store that urine until it is ready to be voided from the body. Getting into the histology of the ureter here briefly. So the ureter really is consisting of 3 layers. So if I were to take my ureter, chop it in half, I would see 3 different layers going from internal to external. So the innermost layer is called the mucosa. And the mucosa is nothing but the epithelial lining, so the epithelial cells that line the bladder, along with connective tissue. So epithelia plus connective tissue forms the mucosa. The second layer is that middle muscular layer. This constitutes a longitudinal layer along with a circular layer. So this is all smooth muscle, just to remind ourselves. So we're not voluntarily controlling this type of muscle, but it's got 2 orientation to the fibers so that it can help really propel that urine along the tube here. So it's got a circular layer of muscle that kind of, changes the diameter of the tube. And then it's got a longitudinal layer of muscle that will change the length of the tube. And together, when those muscles alternate in their contraction, they help to propel that urine down toward the bladder. And then the outermost layer is the adventitia. And this is really just fibrous connective tissue. So it's a tougher, sort of thicker layer that is made of connective tissue that is helping to anchor the bladder, but also just protecting the bladder as that outer layer, and that is called the adventitia. Okay, and this trend where we see mucosa, muscle, and connective tissue is going to be something that's seen throughout most of our tubular structures. So we'll talk about the GI in our next unit, and we'll see that same trend. There's an inner mucosa, there's a middle muscular layer, and then there's that outer fibrous connective tissue called the adventitia. All right, getting into some of the differences that we see with the urinary bladder as it pertains to males versus females. So males have the bladder that is at the base, sort of in between the rectum and the pubic symphysis, or the pubis symphysis, which is that cartilaginous connection between both halves of the pubic bone. So because males do not have a uterus, the bladder is just right behind that bony connection there. And then the rectum is going to be posterior to the bladder. Alternatively, in females, we do have that large uterus in place. And so the bladder is going to kind of be squeezed, right, shoved right up to the anterior of the vagina, and it's going to be nestled in between the rectum posteriorly and the vagina anteriorly. And so that's going to play a really big part, especially in females when they become pregnant. The bladder kind of takes a hit as that uterus starts to expand and grow and occupies more space in the pelvic cavity. Okay, we'll point some of that out here. So here is what a mid-sagittal section, of a male pelvic region would look like. And so we can see some obvious structures here, right? We've got the penis, we've got the testes, we've got the bladder here. This is that pubic symphysis. So this is the cartilaginous connection between both halves of that pubic bone there. And then we've got some other smaller structures, such as the prostate here, the seminal vesicles posteriorly here. And what we really want to point out is how the bladder is sitting between the rectum posteriorly. So here's the rectum, and that bony connection, which is the pubic symphysis anteriorly, because it's got a lot more space in males. It's not really going to be affected in terms of space being occupied in males. Contrasting that to what we see in females is that we've got the uterus here, okay? We've got the bony pelvic connection here, and then we've got the vagina here as well. So the vagina and the uterus can sometimes squeeze the bladder in between, especially if the woman is pregnant, where the bladder sort of obnoxiously takes up way more space than it usually does. So it's going to extend over top the entire bladder as the abdomen protrudes. And so the bladder kind of just gets crushed in between the vagina and that really large expanding uterus. Okay, and so we've got the rectum posterior to the uterus and the vagina. And so this is why in males, if we're doing a bladder inspection, if we're doing a prostate inspection, we can use the rectum as a route to palpate the bladder for any tumors or anything like that. But in females, that's not as effective because we've got this structure sort of obstructing that palpation. Okay, excuse me. I'll pause here and see if we have any questions on any of that so far. Okay. So looking at some of the ligaments that help to anchor the bladder in place, we've got the median umbilical ligament and the lateral umbilical ligament. And these ligaments are actually modifications of the peritoneal fold. And we'll talk all about the peritoneum in lab, right? It's kind of that membrane that encapsulates all of the abdominal contents. And so it kind of modifies itself at the base to form these two ligaments, the median umbilical ligament and the lateral umbilical ligament. The median ligament extends from the top. It actually goes all the way up to the posterior aspect of the belly button, right? The abdominal region. And it's what used to be the urachus. So the urachus was the tube that would take waste from the fetus to the mother through the umbilical cord. So this used to be your mom to baby connection, but then that was obliterated when we cut the umbilical cord. That is obliterated, and we still have that ligamentous connection from the top of the bladder to the posterior aspect of the belly button, the umbilical region. And then the lateral umbilical ligaments, there are two of them, one on either side, help to do a similar function. They anchor the bladder in place, but they attach to the lateral aspects of the abdominal wall. Okay, now looking at the histology of the bladder is formed mainly by the detrusor muscle. So the large muscular layer of the bladder is called the detrusor muscle. And while it's not listed here, we still have those two other layers that I talked about. There's the inner mucosal layer and then that outer adventitia. But the main change here is that the detrusor muscle is a large, bulky muscle, smooth muscle that forms most of the bladder wall. Okay. We've also got two other muscular structures here. We've got the internal urethral sphincter, which is not under our voluntary control. So it's going to be located at this region here. So it's really at the base of the bladder, at the base of the trigone. And for demonstrative purposes, we're showing it here in males. So the structure underneath is going to be the prostate. And so the first opening from the bladder is going to be the internal urethral sphincter, which is smooth muscle. We've also got the external urethral sphincter, right? This is the part of the urethra that comes through the diaphragm here, basically through the floor of the pelvic cavity. And here we have another group of sphincter that's called the external urethral sphincter, which is under our voluntary control. So we do decide when to open the sphincter, when to relax this muscle, and we can void urine versus when to, contract it and hold it and to hold urine. We may lose control over this sphincter. So during infancy, we don't have as much control. That's kind of the first part, right? So this is why we potty train toddlers, because they don't have as much voluntary control and decision-making power to keep this sphincter closed and contracted. But then in later ages, right, as we age and as we go through different changes, if there's any type of spinal cord injury, we can eventually lose control of this sphincter once again. Okay. If we're frightened or afraid, we can also lose control over the sphincter. So that's another kind of element there. The sympathetic nervous system can sort of override this, and we can, just urinate on ourselves if we have that, that type of experience, that type of fear or being afraid or anxious. So let's talk about some of the other differences of the structures here. So looking at the urethra, there's another substantial difference seen between males and females. So females have a much shorter urethra. This is pretty much why we see things like urinary tract infections more often in females. There's a shorter length for bacteria to travel from the external orifice up to the vagina, not the vagina, excuse me, the bladder, and then eventually the kidneys. And so because of that shorter length, about 3 to 5 centimeters, we often see more UTIs in females than in males. Males, however, have a much longer length to their urethra. It's about 18 to 20 centimeters. And so there are actually 3 different parts to the male urethra. There's the prostatic urethra, which goes through the prostate gland. We kind of showed that a little bit earlier. There's the membranous urethra, which is a very short segment. It's the shortest of the 3 parts, and it goes through the urogenital diaphragm, pretty much that area that has the sphincter, the external sphincter that we pointed out. And then the third part, which is the longest part, is the spongy urethra, sometimes called the penile urethra, which goes right through the entire length of the penis and goes out the external urethral orifice, okay? And the word orifice just means opening, right? So the opening out of the body cavity, we've got the oral orifice, the nasal orifice, and so orifice just means an opening that exits a body cavity. All right, so just pointing out some of those differences here. In females, we've got this short urethra here. Here we go. So here's the bladder, right? Anterior to the uterus and vagina, here's that bladder. Here's that very short 3 to 5 centimeters urethra. And so it's a very short distance for bacteria to get from here at the orifice to here within the bladder and even eventually up to the kidneys, okay? Contrasting that with what we see in males is we've got a very long urethra. So the urethra goes from the external orifice here at the tip of the penis, it goes all the way up. So this first bit is the spongy or the penile urethra, it's the longest part. This very short distance here, so this is the urogenital diaphragm, also known as the floor of the pelvic cavity. This is also where we have the external urethral orifice, so the one that we can voluntarily control. And that short length of the urethra that goes through that urogenital diaphragm is called the membranous urethra. Okay, that's the shortest part. And then lastly, we've got the prostatic urethra, which is the bit that goes from the trigone, right, the base of the bladder, through the prostate, which is called the prostatic urethra. Okay, so prostatic, membranous, and then the spongy urethra. Let's talk a little bit about the maturation reflex and how we can control that, which is objective 4. So pretty much the bladder we know is storing urine until it's time to be voided. And there are 2 controls to that. There's the internal urethral sphincter, which we do not control. It's smooth muscle, so it's under involuntary control. And then there's the external urethral sphincter that we do have some voluntary control over. So the first urge to urinate will come when the bladder fills to about 200 milliliters. And again, that trigone, that triangular region at the base is really what's responsive to the amount of volume that has been filled, depending on how much that area has been stretched. And so at 200 milliliters, we're going to get that sensation to open up the internal urethral sphincter. But we're not going to urinate or void just yet because we're still controlling that external urethral sphincter, which is going through the urogenital diaphragm, right, the floor of the pelvic cavity. And so we can decide to void if we make that decision, if we get to the restroom in time, But unless that happens, we'll just continue to fill more urine from the kidneys coming down. At about 500 to 800 milliliters, this is where we override that external urethral sphincter. So when the bladder fills beyond that 500 to 800 milliliter mark, we no longer can keep that urine in. And so we're going to override that skeletal muscle, which is the internal urethral sphincter, and we're going to open up that sphincter and we're going to void. This is what's responsible for having an accident, right? Urinating on yourself, even things like incontinence, because of that, that threshold where beyond 500 to 800 milliliters, the bladder really cannot hold or distend much more. And so we're going to override that external sphincter and allow that urine to be voided. And on this last slide here, we're pretty much just touching on some of the age-related changes that are seen in the urinary system. And this is really just an overview, a little bit of a side story, but I do teach a course, Bio of Aging, and we talk all about the various structural changes and functional changes that are seen throughout many different body systems. This feels like a shameless plug, but basically this is kind of just scratching the surface of some of the urinary changes that we see, but there are a lot more functional and structural changes that are happening in the background to result in some of these changes that we see. So we see that the nephrons decrease in number as a part of age. We see the GFR, so the rate at which plasma is being filtered across the glomerulus. This is called the glomerular filtration rate. That declines substantially beyond the age of 60. And again, this is really an extension of a vascular change. So because the vessels change, because we actually see less cardiac output coming to the kidneys, by extension, we see a decline in GFR. So again, there's some underlying other systemic changes that are resulting in some of these structural changes here. We also see reduced sensitivity to hormones such as ADH, resulting in incontinence and sometimes frequent urination. So because we don't have that ability to really hold on to fluid, to kind of reserve fluid via the function of ADH, which we'll talk about later on, we pretty much lose urine. This can result in dehydration, and again, things like incontinence. And then other structural changes we see are loss of muscle tone to our sphincters. And this is another problem or change that is a result of another systemic change. So all of the skeletal muscles exhibit wasting, right? The muscles of our limbs and the diaphragm, all of the skeletal muscles experience or exhibit some type of wasting beyond 60. And so, excuse me, by extension, when the sphincters undergo that wasting or that loss of muscle tone, that results in incontinence here in the kidneys. And then lastly, urinary retention may lead to infections. So because of a change in the immune system. So as I mentioned, many of the changes that we're seeing here in the kidneys are really happening because of other systemic changes. So that decline in immune function results in more frequent urinary infections, especially if we're retaining more fluid in the bladder, whereas in normal healthy adults, that's not so much the case.